Okay, in the trenches. Today we're going to talk about stroke. That was the requested topic. This is a big topic, and I'm certainly not going to be able to do this entirely. Now, this has really changed. Okay, we had these concepts, TIA and stroke. Okay, and TIA was symptoms reversed within 24 hours. Okay, although usually the symptoms reversed usually much quicker, often in under an hour. We're going, and this isn't exactly cutting edge, from a time-based to tissue-based. So you look at an MRI, and if there's evidence of infarction, whether the symptoms have gone away or not, it's still a stroke. And that's actually what's known as CITS. Clinical infarction transient symptoms. So that's defining a stroke. Now, somebody coming in with a stroke, acutely, what are you going to do? They have symptoms, often, but certainly not always, they're in the middle cerebral artery distribution. Say a patient comes in with a hemiparesis and an aphasia, need to evaluate them. You're going to look at their vital signs first. Okay, and if the BP, unless the BP is sky high, you're not going to treat them. You're going to let something called permissive hypertension occur, and that actually increases blood flow through collateral vessels, and if you bring the blood pressure down, you could perpetuate the stroke. There's also something known as cerebral autoregulation. Cerebral autoregulation, where normally in a normal person, if your blood pressure gets too high, you get transient vasoconstriction. And if it gets too low, you dilate to preserve the brain. Okay, you lose this with stroke. You lose it with stroke. And you have to be very careful about lowering the blood pressure. Now, if you're going to give thrombolytic agents, that's a little bit different. Okay. Next point is, after you stabilize them, you're going to do a CT of the head. Now, CT of the head acutely may not pick up stroke, or there just may be subtle implications there, but it's going to rule out a bleed, and you have to do that. That's one instance where you need a CT of the head. And then you're going to have to make a decision what you're going to do. Okay, so there's thrombolysis. And there's catheter thrombectomy. It's a stent thrombectomy. They don't put in the stent, they take out. And there are combinations of all these. And each year there are more and more studies, and we're delaying the time for how long you can intervene. And they're often looking at a PET scan, an MRI, or a CTA, looking for salvageable tissue. So a key word to know is penumbra. Penumbra is the area of the brain that's ischemic but not infarcted. So you have a core infarction, and then around that you have a penumbra, and that's salvageable tissue, and that's what you want to help. Okay, so all this with the studies, and there are a lot of them, started in December 1995 with something called the NINS trial. It was an NIH-based trial, and they gave TPA, and it showed that if you give TPA, okay, and the dose is 0.9 milligrams per kilogram, if you gave it within 3 hours, these people did better. You could get them functioning, you could get them back to work. They looked at indices called the Barthel Index, and the modified Rankin index. Okay, and that's basically, it showed that you could get these people better. Not remarkably better. It's not that somebody will be lying in a coma and you're going to give them TPA and they're going to get up on the gurney and start dancing. But this was really the first data showing that you could improve the outcome. Now it had to be within 3 hours. So they went out in the community, and this is pushing 30 years now, and they started making people, the public, aware of what was called the stroke attack. Like people were aware of heart attacks, and they advised them to get medical help, to go to the emergency room as soon as possible. Now, there were problems with this because you could get intracranial bleeding with TPA, and before that they had studies. So this kind of achieved the right time and the right dose. Okay, there was another study done a little after that called PROACT 2, which was done in Cleveland, which showed that you could give intraarterial TPA. Actually, pro-urokinase was the thrombolytic agent up to 6 hours, but that really didn't take off. The next study that came out was something called ECAS 3. It was done in Europe, and it basically extended the time window out to 4.5 hours. Then, within the past 10 years, there have been a myriad of studies, and I'm not going to go into all of them, I do not have time to do that, that showed that by using stent thrombectomy, you can improve outcome. And some of these were combined with intraarterial TPA, some were combined with IV TPA. The first round of tests, were actually negative, and then the second generation, a year or two later, 1 year, there were like 5 tests: Swift Prime, Revastat, Mr. Clean. They had all these tests showing that there were 5 studies that came out within 2 New England journals: Swift Prime, Revastat, Mr. Clean. I'm doing this off the top of my head. Escape, I think, and something else. But whatever, it showed that. And as time went on, you started seeing more tests showing that you could prolong the time to which you can intervene with patients and get positive results. And also, even up to 24 hours, and you would use imaging, seeing if there's salvageable brain tissue, either an MRI or a CT perfusion scan to see if there is intact tissue. That's really the key here with stroke. Okay, as far as causes of stroke, most common causes carotid disease, not necessarily tight carotid stenosis, but the greater the stenosis, and then the mechanism isn't including a carotid artery, it's plaque breaking off and going distally. That's the number one cause. And the other major cause is atrial fibrillation. People who have idiopathic strokes, when they studied them, they showed close to 30%. If they put a loop recorder in these patients, they have evidence of atrial fibrillation. They need to be anticoagulated. Now, based on the degree of stenosis, you're going to think of revascularize them, often an endarterectomy, clearly with 70 to 80% stenosis if they're symptomatic. And these carotid studies really started in the early 1900s. So the points I want to make here, you got to evaluate them. The earlier the better. Evaluate them for lytic therapy and stent thrombectomy, and then you look for the cause. Now, if they have carotid disease, you may need revascularization. If you have atrial fibrillation infarction, you can't anticoagulate them right away. And when you're going to start anticoagulate them really depends on the implant. And although aspirin has some good data, very good data for secondary prevention and possible primary prevention, in acute stroke, if you can, and this is data from the 90s also, you should probably give a baby aspirin also. And these patients will need to be placed on statins, but acutely, you want to find out if they're candidate for interventional therapy, and with that, I'm going to stop.